Good morning and welcome to the Health and Adult Social Care Scrutiny panel. Minutes of previous meeting. Did the panel approve the minutes of the meeting held on the 16th of January? Yes. Thank you. Are there any items that any member wishes to bring up on the minutes at this moment in time? No. Thank you. Interests. Does any member have any interests they wish to declare at this point in time?
Yeah, I think I have to declare that in relation to, I'm not sure, the agenda items, but there's suicide prevention. I'm in the South West Yorkshire Partnership NHS Trust. I'm not sure it directly affects that item, but just in case.
Thank you. Are there any other interests?
Yes, on item 4, just to confirm an amendment of that.
Okay, thank you. There are no items that are confidential, so all items are in public. So do we agree to the meeting? Yes. Okay, thank you. Right, update from Locala then. We have this morning got James, Sarah and Claire. Perhaps you could introduce yourselves before you start. We have received your papers, thank you very much, and read them through. So is anybody just wanting to give a summary or an update before we move into questions?
Yes. Sarah, you're going to go first.
Yes, I don't know if you want the summary on the podiatry, where we are with that. That's quite a straightforward timeline. So you might
give you that first and then we'll go to the general updates on the things. So if you introduce yourselves first.
Yeah, my name's Sarah Crew and I'm Customer Engagement Manager at Locala, and we're, as you know, running the podiatry consultation. We're bringing that to the Open Scrutiny at the next meeting on the 13th of March. So I've prepared a timeline so you can see where we are with that and the various places we're going to be updating before the Open Scrutiny meeting next month.
My name is Claire Jones. Forgive me, I'm full of cold and grottiness. I am Director of Nursing and Quality at Locala, and I am taking the lead on the CQC quality improvement work that we're underway with at the moment.
I'm Jane Close, Director of Operations. As a running theme, I'm also full of cold, so apologies. I lead all of the operational business, so the updates that you've got are on the admission avoidance work. I've got a verbal update about Maple Ward.
Okay, thank you. Alright, let's do podiatry first, then mention podiatry, and then we'll move to the CQC and the winter pressures and the monthly. Okay.
Yes, so we've got going through the appropriate governance, as you can see from the paper, and there's a time scale set out below. The CCGs, it is their responsibility as well to look through the governance that they're doing. We're writing recommendations at the moment based on the feedback that we shared with you last time. So, like I said, we'll be presenting that at the next meeting. You've got the meeting dates there, and there's one to add to that. On the 7th of March, we'll be attending the joint clinical strategy group meeting as well. I don't know if there's more I can update you on.
Can you just give a reason why the timetable has changed? Because your timelines have changed from when you came previously, haven't they? So is that just assessment of the information that's taken longer, or
it's taken longer, and finding the time to get the right people in the room with some of the clinical pressures we had over December. There's a lot of feedback and there's a lot of information to go through. We're going to do it properly and give a full and thorough recommendations when we do that. And so I did apologise.
Yeah, no,
we were just it was just a difficult time, and we struggled to find the time to get all the right people in the room at the same time. But we're on schedule now, so it meant a full week delay in coming to open scrutiny with that.
Because there was concern, wasn't there, about the pressures of the lists as well for podiatry while you were doing this consultation as to the service levels that could be maintained and everything. So have those been maintained, and the waiting lists for seeing somebody not getting longer or anything?
No. They're fine.
The services are right at this point in time. Yeah. Does anybody have any points on podiatry? Because which is why I was asking about the workloads. Okay. All right. So do we want to move on to your CQC governance?
Yeah, okay. So you'll be aware that Locale was inspected by the CQC in October 2016, and whilst the organisation has got a number of good ratings across a number of services, we did pick up 2 inadequate ratings, one for our intermediate care facility at Maple Ward in Home Valley Hospital, and the other one related to our integrated community care teams. One of the golden thread, if you like, that ran through the subsequent reports that were received from the CQC related to our quality and safety systems and processes across the organisation, and lack of embeddedness, or indeed lack of, in their entirety. I'm quite proud to be able to report that the position we find ourselves in today is much improved, significantly improved, and that position has been quality assured by a number of external sources, including our CCG colleagues. We've had external scrutiny from one of the directors in South West Yorkshire Hospital, mental health hospital. I said that. And we have got real levels of assurance that the quality and standard of our quality and safety processes are much improved, and our patients are receiving a much greater quality of care. What we have done is we've established quite a strong and robust governance process that wraps around the delivery of our improvement work. I report to the Locale Operational Board monthly, the CCG Quality Board monthly. We have, Jane and I meet with the CQC on a relatively regular basis, where we have CQC relationship meetings where we are asked and obviously appropriately scrutinised in our delivery plan. And we have a weekly CQC Quality Improvement Plan delivery group where we track our improvement. We have made giant strides in terms of delivery of the plan. In overall terms, as I've detailed in the paper, we're about 84.8% of the plan delivered, and the rest of it is very much there or thereabouts. In terms of demonstrating to you how we have made the improvements that we wanted to make, I presented the paper against the 5 key CQC domains against which we would get inspected. So that's safe, caring, responsive, effective and well led. And I don't intend to work through each of them, but against each of those headings we can demonstrate some really robust improvements that we've made in the last year. I'm happy to take any questions on the paper.
Do you want to get a glass of water?
I've got a glass of water back.
On page 14, evidence of progress. Overall, terms at 84.8%,
yeah,
and have been delivered, and 9.1% is yet to be delivered, and 5% is on hold. Can you quantify some of that? The 9.1%, what is that, and the 5% on hold?
So the 5% on hold is the Maple Ward, the actions relating to Maple Ward, which is, as I say, is currently closed. So we've not been able to progress delivery of those actions. Those remain in a holding position. And the 9.1% yet to be delivered are actions that have got an amber status. So the things that are actually in train but we haven't yet delivered. So they've probably got a delivery date of February, March, April time. So they're actions that are underway.
We haven't got that.
Actions of what would be nice, because 9.1%. I mean, actions of amber and red and green and things like that and blues. You know.
I haven't included the delivery plan because the number of actions in it is in excess of over 200.
Yeah.
So I thought it was slightly unwieldy to present you with that. The headline figures in terms of our progress against delivery. I made an assumption, probably wrongly, that would be okay. I'm more than happy to provide you with the detail of the plan, but it is extremely detailed operational detail, but again, if that's something
Maybe
would like
you
to
could
see.
let us know the 9.1%.
Yeah, it'd be just nice to know what the 9.1% is.
I think it's worth me clarifying and just dwelling on that for a moment, because it's not actions that have not been delivered and are behind time. It's actions that were always scheduled to be delivered in the coming months.
Yeah, but I appreciate that, but it's just what are those actions? And if it's a 200-page document, and we're saying we're putting a figure on it of 9.1%, we're saying these are the actions that haven't been delivered. I appreciate it's a massive report, as you're saying, but it'd be just nice to know just what those actions are.
What kind of actions? And
Yeah.
I can give you a flavour of what they are. Some of the actions relate to our patient record system called System 1, which is our electronic patient record. We're doing quite a big piece of work looking at that, and there's probably a number of actions that actually pertain to that one piece of work, but they're all subtly different. And in the majority, that is the main. The other outstanding actions relate to some of our estates work, which is ongoing at the minute. And that again is work that is planned and is happening, but we didn't ever anticipate it would be delivered until the early part of this year. So in presenting that picture to you, it's a really positive position, not something that I'm saying actually we're concerned about in any way.
And in terms of that 200 actions, what Claire and I did was we pulled out all of, obviously in the CQC report you get your list of must do, should do's. We pulled those out and then we pulled out, extrapolated everything else as well, hence the 200 action document.
Yes, so how many of your 9.1% that you're working on at the moment is part of your must do, and how much is part of your should do?
Yeah.
There's none of them. No, none of them. All the must do's and should do's have been delivered.
And they've all been
Yeah.
delivered.
Yeah. What we also did was we went through the CQC plans and the CQC reports. We pulled out the must do's and should do's, and we also identified things that the CQC had mentioned, not with a must do or a should do tab, but things that we felt that were implicit within the report that actually would be missing a trick if we didn't pick up and turn into an action for our organisation. So all the must do's and should do's have been delivered.
I was shaking I discussed the numbers earlier. I was of a very similar mind, but I must be honest, from what you've just said, it sort of reassures me a little bit. So the 9.1%, we've just discussed that, and you said, I think, that there is a plan to do that by April, May, April.
It's in the early part of this year.
So
yeah.
What I'm getting at is the 9.1% has got a date attached to it.
Yeah, everything's got a date attached to it, and as I say, as part of the governance of the oversight group, I hold people to account every week on delivery of those actions.
Okay, fair enough. I mean, to be honest, I agree with the level of detail is probably about right for this report, to be honest, but I don't think we need the further, now qualify what we discussed just now. That's just my view.
I think it would be good if we could have some more detail on the 9.1%. Just give some detail as to what they are. We don't need the full action plan, but we just need to know what they are and when you're planning to do them.
Okay.
That would be helpful. Yeah.
And it might be, given it's 18 months ago or however many months since they actually might be an idea to add the things that they didn't tell you about that you're going to do as innovations.
Yeah.
You've also, your added value.
Yes.
Yeah. So Peter, you wanted to ask it?
Yes, I mean, I don't want to kind of dwell on you. I can kind of translate the way the CQC report comes into your the bullet points, and just wondered again. It's really about exemplars, because I think the list is kind of fine on the surface, but it gives a lot of detail. So, for instance, you talk about safety. You tell us about adverse events, and you don't have many. So how do you learn from adverse events elsewhere?
In other organisations?
Well, the literature.
Yeah, I mean, we have
I'm thinking about clinical stuff, because, sorry, I should have prefaced the remark, this is very, very good on governance and organisational detail, that, if I was a district nurse out in Perth this morning, how much of this is going to impact on what I do for Mrs. Hicks?
Okay, so starting kind of within our organisation, we've got a number of we share learning across business units. And one of the things that was introduced in the middle of last year was the Patient Safety Summits, which we hold every month. And we take examples of incidents that had happened in the preceding month. And the invited audience are a cross-section of people from across the organisation. So we have people who aren't clinical, people who work in different business units, or a whole range of disciplines of individuals who come along, and we talk about each incident. And it's usually presented by the person that was involved in that incident, which makes it even more powerful. The learning is then extracted from it in a way that we probably wouldn't do at any other time. We actually allow ourselves time to sit and pull the incident to pieces, thinking about the human factors associated with why incidents happen. The outputs from those meetings are then, thank you very much, are then put into a mail shot that goes around the entire organisation, and it's shared at team meetings, it's shared at safety huddles, it's shared across every opportunity that teams have to come together. The Safety Summit Snapshots, as it's called, is shared there, and it's publicised in a whole range of ways. In terms of learning from other organisations, I meet with my counterparts in both of the big acute trusts on the patch, where we have an opportunity to share learning between each other. And from a locale perspective, we're an organisation that really encourages our colleagues to attend conferences and events, and where there are national opportunities for learning, we make sure that colleagues can get out and attend those.
It really needs to know if you're using live events or live instances, as you just said, you get people to bring a case. Where does in all of this, where does clinical audit fit in? I know that's not about this day because it's not about learning from good things that happen.
Yes.
But how does that happen? Is there a systematic?
There is.
Because they talk about record keeping in CQC, and it's not just about what you write down; it's about what you do as well.
Yeah.
I know the two go together, but
I'll be.
What that is in the industry.
Yeah. In being perfectly honest, when I came into post a year ago, the priority for me was to establish some robust methods that we could report incidents and learn from incidents and employ and deliver duty of candour in a better way than the organisation had done before. So I think it's fair to say last year those were my areas of priority which have been delivered and are now embedded across the organisation. Moving forward into, if you like, 18-19, my areas of absolute priority are clinical audit, learning from NICE guidance, and a number of other slightly more affiliated quality topics, but things that don't sit right at the heart of quality. Clinical audit is something that we are passionate about as an organisation, because that whole learning and having the opportunity to then audit our improvements is something that we want to get better at. I'm not saying it's not happening, I'm just saying it's something we need to get better at. We've established a new clinical audit and effectiveness committee that is sponsored and attended by one of our non-executive directors, who has got an absolute passion for clinical audit.
And how does that relate to the clinical educator?
The clinical educator role. The clinical educator role in integrated adults is a relatively new post, and that individual has when did she come into post, Jane? Was it
About 2 months ago.
Yeah. So she's just finding her feet in that role. Her early area of work has been about competency development within the integrated adults workforce. But there is undoubtedly going to be a dotted line into the clinical audit group, because the work that she's undertaken in that environment, we would want to audit from an improvement methodology perspective to make sure that what she's doing is having the desired effect.
Just one last little one for me, which brings us into clinic effectiveness and how you're measuring it, because you seem to put a lot of store on people being complimentary about what you've done, and we do know from the evidence that the older you are, the more likely you are to say it was all right, whether it was or not. And you seem to put a lot of store on that. I'm not saying you shouldn't, but are you using any kind of formal tool? I mean, obviously there are outcomes. Is the patient alive or dead? Obvious outcomes. But are you doing anything in addition to that that really summarises your performance? and the patient experience.
Yeah, we're doing an awful lot of work in all of those areas, really. I mean, Sarah leads on the patient experience element of that, and we've got a whole range of different approaches to that, some of which have been around for some time, some of which are new and are just being developed, stuff relating to patient opinion and
Patient opinion, and in the next couple of months getting together, we're getting focus groups of people who've been through the adult therapy and getting more opportunity to speak to patients on a face-to-face basis as well, rather than just relying on the traditional friends and family and patient surveys. So we're doing a lot more face-to-face work as well.
And then some of the hard measures in terms of operations are some of the admission avoidance work, the intervention, something around actually when we finish the reablement element of that patient's care, do they need a long-term package of care? Do we make sure with the local authority that we actually keep people for as long as we can in their own houses?
Yeah, I think we probably come back to that a bit later. in the second phase.
Yeah.
Thank you.
Yeah, appreciate the CQC report, the large report, and lots of lines of action coming out of that, so to reproduce that would probably not be helpful. I did find that a bit difficult in the domain areas, each of which is headed, we can demonstrate improvements, to link those bullet points back to what the CQC concerns might have been, because I'm not sure what those were. I mean, I've probably read them before, but I've forgotten. So on some of the we can demonstrate improvements, the bullet points don't actually demonstrate improvements, they're statements. So safety performance is measured rigorously, reported at board level internally. It doesn't say anything in detail about safety there.
Just to kind of hone in on that one, I think that point in terms of an improvement, without the context, I understand it doesn't provide you with that information. Knowing what we know as an organisation, that and you'll see from the governance paper that was submitted as an adjunct to this, our board meetings only used to take place once a quarter, and safety performance data was scant at best. It's now our operational board meetings are monthly, and I am held to account really strongly and appropriately by the board and the non-executives around quality and safety in our organisation. And I think that's the difference. So whilst the context isn't there, probably taking your point, it almost should have been this was how it was and this is what we've done.
That's what I think would have been useful. There were a couple of things, examples, the 0 never events, 9 serious incidents, and then in the second section on caring, an average 8 complaints per month over last year. But to demonstrate improvement, we really need to know, well, what was it before? What is it now? What's it projected to be? So that would be helpful if you're trying to demonstrate improvement for us to see that. What I was reassured by, which you kind of play down here, is that you've done all the must-dos and the should-dos. It doesn't actually say that here. It refers to them, it doesn't actually say you've done them all. So, I mean, which is good to hear, because those are the important areas. I think the other thing is just on the, you mentioned at the bottom of the first page of the report the number of forums that consider these items. And there's also a fairly complicated table, a diagram, which shows the interrelationship between different parts of the bodies that are involved in this process. Is there one body, group, committee that has responsibility for delivery of the improvements in relation to the CQC plan, and the other input go into that body, but that body says yes, we're the responsible body?
Yeah, we have a delivery group, and that's the group that I mentioned I chair on a weekly basis. That feeds into a whole range of different groups within that structure, but the other key subcommittee of the board is the clinical quality group that has oversight of the delivery of the plan and the progress that we're making in terms of our CQC journey.
Right, so if something's not done, people will come back to the weekly delivery group to say, look, this hasn't been done, what's happening? Yeah. Okay, thank you.
Some of the questions I was going to answer have already been asked, but the 9 serious incidents, in terms of what, up till now it's been 9 serious incidents. When were these incidents reported? It was after you came into, and after you obviously in terms of putting actions into place in terms of what's been happening before, and what have been the outcomes for that, and what kind of learnings have you really taken away from those incidents, and how have you managed to put that through? I like details, and I have an issue with the report itself. I find it quite weak. It just gives me an overall overview. I don't want 200 points of what you want to do, but I find it quite weak in the sense that there's not enough information to kind of relate to. And I understand that this is your first time coming here and to be able to put this through to us, but in future I probably want a lot more come through to us. Again, about the complaints, my colleague did also put through 8 complaints per month that you're getting. What age groups are you getting the complaints from? What kind of complaints are there? What are the outcomes? What kind of outcomes have you had from them? Got nothing to show of that. I mean, these are the stuff that obviously has been highlighted on the CQC reports that you need to do some work on. You've recognised that. You've literally just given us saying that this is happening. That I'd like to get some more information on that.
Okay. Do you like me to?
Yeah, it would have been nice.
And the complaints.
Yeah, it would have been nice to have a lot more information on that.
Okay, and would you like me to provide that to you verbally now?
Yeah, I would have liked it already in this report beforehand. Being able to actually.
So the premise of what I was asked to produce for the meeting was an overview of our CQC improvement journey. With the greatest respect, if I've been asked to produce a report around our serious incidents, prevalence, learning, and complaints, prevalence and learning, of course I would have done that without a problem. I can provide you with some high-level information I obviously carry around in my head.
Just background information, just to relate. Not the total, like I said, like you mentioned before, not the total 200 points of whatnot, but a little bit more in detail about a bit more, so we get a better picture.
It would have been good if you used examples.
Yeah, a better picture of what's going on.
That's what we're asking for.
Yeah, it's just a better picture.
You're in your paper, you're making some sort of general statements, and it would have been good if you'd back that up with examples as to what you're doing, wouldn't it? So, about the serious incidents and the learning from them and everything like this.
I think the councillor's point, really is, are you marking your own homework?
Yeah. No, we're absolutely not. The amount of scrutiny that we get from our CCG colleagues is overwhelming at times, appropriately so. But the confidence that they now have in us as an organisation is mirrored in our monthly quality board that we attend, whereby it's much more light touch than it was 6 months ago, because they have absolute confidence that we're doing the right things. We share with them every month the progress we make. As scrutiny meetings go, it's quite hard hitting, but again, that's appropriate and that's what we expect. In terms of things like our serious incidents, we benchmark nationally in a very, very positive way. We submit all our data to a national reporting and learning site that is actually an NHS benchmarking site that for a number of years we didn't have access to because we're a social enterprise. But in terms of the number of incidents we have, whilst 9 may sound a large number, it's actually well within our pack in terms of other organisations of a similar size.
But without having that background information, looking at that and just them few lines on that domain part of it, it just looks like a bigger number than 2 basically. So having no background information on that is what's a concern here. I mean, even on the well-led, you put down chat with Nat, and I've got no idea what chat with Nat is. I'm assuming it's a team leader or a group session that you're having or something like that.
It's our interim chief executive is called Nat, and it's a monthly meeting where colleagues
just a bit of a comment as to what it was and whatever.
Just as well to qualify Mark in our own homework, it's probably worth as well saying that CQC, the relationship managers as well, have taken a really different stance. CQC as a whole around inspection for this year, so they've actually met with some focus groups of some teams already and have asked the very questions that we're providing assurance with. And I think we were meeting with them every month. They've actually dropped that relationship meeting now down to every 3 months. They're coming next week,
next Tuesday,
to have oversight of our governance meeting, which is called Stand Up Tuesday, where all of the different business units and corporate enablers are held to account across their performance.
I didn't mean
No,
you were marking your own. I just meant that that you know that it's not obvious.
Yeah,
That's the point of it.
Just before I bring the next question in, can you just clarify this on this serious incidents? So it would have been good if you could have given examples of the serious incidents and the complaints, because you have something in your governance that says complaints closure group. Now, when you just read the paper, that looks as if that's a group to say, well, have we dealt with it, we'll close that complaint. But it's the learning from the serious incidents and the complaints group that I think we'd like assurance of, that is actually being embedded in the organisation. Maybe it's just that your name of your committee might be skewing that perception. So how do you actually, you said that you complain against a timely response, etc., and there's new KPIs, but how do you then look at the complaints, the serious incidents, and how does that committee that you've got there actually look at the learning from that and actually put it in different procedures where needed and things like that? Because, you know, that looks as if that committee is just to like close the complaint, and that's probably the perception of the name of the committee.
Okay.
Yeah.
So currently we have 3 business units within the organisation, and each business unit has its own management structure. Attached to each of the business units is a quality assurance manager who covers all aspects of quality, including complaints and serious incidents. So at business unit level, incidents are investigated, complaints are investigated, reports come to the central quality team for quality assurance. We share them with our CCG colleagues. At business unit level, we promote and encourage and successfully have embedded learning at that level. So at the point when where incidents have happened, the learning is extracted and spread across those teams immediately. We've put in place across the organisation as well 48-hour reviews for anything that we suspect could be a serious incident or just an incident that causes concern. That is incredibly responsive. If you read all the national evidence in relation to the management of complaints and incidents, having a virtual panel, which is usually a telephone Skype call, where we review in detail the circumstances surrounding each and every incident and complaint that we receive within 48 hours of the complaint being received or the incident happening, is an absolute gold standard practice. So that happens, as I say, the incidents are looked at, investigated at business unit level. The learning is shared at business unit level. It is then shared with the quality team, and it, as I say, is then shared out across the organisation through a number of different forums that we have in place. In terms of the complaints closure panel, that is where I sit with one of our non-executive directors and the head of complaints, and we look through each complaint that we have had into the organisation in that last month. We examine whether we feel we've responded appropriately, whether we've responded accurately, whether there's been any further communication back from the complainant following receipt of our complaint report, and then we understand from the complaints manager what has happened back into that business unit in relation to the learning, sharing of learning, and what mechanisms have been put in place for that to happen. So it's the complaints closure panel is local terminology that we describe, where we work through and review every single one of our complaints. And having worked in hundreds of NHS organisations, I've never come across anywhere that does this process as thoroughly as it's done in Local.
And if it's not, and if they're not happy, it's not closed.
Exactly.
Exactly.
Yeah. How would I
To some extent, Fazila's actually asked a question that on page 13, your second paragraph, where you've said that you've recognised some of the basic quality and safety systems and processes that you've tried to embed within the organisation. Can you explain what those were?
Sorry, could you just say that again?
In terms of your basic quality and safety systems and processes, you've just made a general statement, but then there's nothing.
The basic quality and safety systems and processes relate in the main to reporting of incidents and incident management. What I did when I came into post was, as I say, set up the 48-hour review panels, which I've just described. So incidents are reviewed as soon as they happen. We then review them at day 30, we then review them at day 45, and we always ensure, in line with the national KPIs around serious incidents, that the reports are submitted to the CCG by day 60. I think in the past, Locala had not applied such an emphasis to delivery of those timescales, which are actually critically important in terms of ensuring that the reports are written and submitted to the CCG in a timely manner. So in the main, it was around incident identification, reporting. We've got an incident reporting system in Locala called Datix, which is an electronic system. It's got multiple facets to it, but one of the areas that is very well used is the incident reporting function. And it was just embedding knowledge and training among staff as how to best use that piece of software. And actually it is very well used now. The key strand to the basic element of quality systems was around duty of candour. And I think duty of candour wasn't terribly well understood across the organisation. I think if you went into any of our teams now and asked them about duty of candour, they would understand. It's just about saying sorry. But it's something that we needed to embed quickly because it's a national KPI that we have to deliver.
Okay, I think it's about the embedding. I think that we got some concern over as to whether that's going through the organisation. You mentioned that your scrutiny committee with the CCG is important as well. But this scrutiny committee also has confidence in where you go and how you move forward with this. Because there was something I remember the CCG picked up that you'd won an award for dementia, hadn't you? But in actual fact, it didn't seem to be embedded across the organisation, I seem to remember. And so there's a lot of plans here that need to be put in place, a lot of strategies, a lot of looking at where you are, etc., and processes that you've had to put in place. But how is that testing that it is that everything that you're putting in place is working effectively across your organisation? How are you actually being able to demonstrate that?
I'll answer that operationally, because effectively Claire holds me to account for delivery. So we're currently undergoing the rollout of something called Know How You're Doing boards. So that's for each team. So we started with the drug and alcohol service and with the integrated community care teams. That tracks the progress of each team every month in terms of numbers of incidents, complaints, sickness levels, mandatory training levels, a whole raft of performance indicators that are then used at something called the quality safety walkabouts. So what we have is we've got various members of the management team and the non-execs with effectively a set pre-script that we would use for the purposes of providing assurance, actually what CQC would use, and actually assuring ourselves that the work that we've put in place, the things that we've put in place are actually operationally embedded. On top of that, then we've got a whole raft of audit to make sure that it is embedded. So if I take something like lessons learned, we've just done, and we do it regularly, but we've just done an audit to say the lessons learned came out of the clinical quality group into our operations meeting, down through the business units and at team level, and it's all tracked, standardised agendas, and standardised things that are covered. So it is, I was only here about 6 months before Claire, it is a world difference to where it was in terms of assurance and governance processes.
So how do people go up? That's okay going down, yeah. But what about good practice going up so that people have an opportunity to say, actually, this is quite good. We found this works.
Yeah.
How do you get that feedback up the organisation?
Okay, so that comes again through a whole raft of work that the business units do in their meetings, through the corporate, the business unit risk register, and then through to the corporate risk log, and then something that we've introduced about 4 or 5 months ago, something called the monthly Standard Innovation Awards. So people are recognised on top of our yearly awards, recognised for good practice. And again, it's back to Claire alluded to the patient safety summit snapshots. That evidence of good practice is then circulated and included at team meetings and safety huddles.
So pretty okay with that paper there, that particular paper.
Just wondered, at this point, do you know what the future of Maple Ward is going to be?
Do you want me to cover Maple Ward now? Shall I give the background first of where we ended up with Maple?
Yeah.
Okay. So Maple Ward is a ward at Home Valley Hospital. I came into post in June 2016 and straight away recognised that we weren't compliant in terms of safer staffing levels. So the RCN guidelines determine that for every 8 patients during the day there should be 1 registered nurse, and overnight 10 patients to 1 registered nurse. So I set about putting in place some recruitment for Maple Ward. Obviously we had in the October the CQC called out a number of immediate concerns. There was then, Maple Ward had its own effectively action plan that was on track, has since been incorporated into the overarching 200-point action plan. But I got to a position last March, April, where we had a situation where we had more people, more staff leaving than we could recruit. And Locala have got a system whereby within the probation period for the members of staff that join us, it's a 6-month probation period, hand the notice in and leave within a week. I took the decision along with the CCG and with Claire that we needed to temporarily close the unit, mainly because I wasn't prepared to run the risk of staffing a unit with agency staff in amongst that the number of issues that we had within Maple Ward. We closed it temporarily in April. We have not, despite a month-on-month recruitment, and that has happened month-on-month, we haven't been in a position up until literally now to be able to open up that ward safely. And again, I'm mindful that I then run the risk that people will potentially leave within a week, and then I'm back to square one. Last September, October, discussions commenced with the CCG around how we might use Maple Ward differently. Maple Ward, I think, from my point of view, has been used not necessarily as a rehabilitation intermediate care ward, but quite as an overspill facility from CHFT. And Maple Ward is considered in the round of what we do around the full intermediate care service offer moving forward. So from the element of the teams that you need to support patients in their own home, through into an intermediate care facility, or indeed a transition bed for someone who's not poorly enough to go into an acute hospital ward, or patients that are coming out of the acute hospital ward aren't quite well enough to go back home. And that, the standpoint at the moment is that the CCG are considering a number of options for utilisation of Maple Ward. Because at the moment, Marion Redford, she works at the CCG, is undertaking the full intermediate care review. Mindful there is one pot of money that we need to carve up to the most appropriate way, and it is my belief that actually the beds that we've got are in patients' homes, and that's wherever possible patients should be back at home rather than in a bedded facility.
Yeah, as you would probably the one pigs out.
No, I was just going to say, but it is a precious facility.
Yes, that's what I was
given
going to say.
that, and I realise you don't want it to be a dumping ground for HRI, which it could easily become.
Yeah.
But I mean, with a bit of thought, it could be well, it's not our business, but it could be put to some use and not be closed, particularly given the pressures that everybody's
under. So to give you some assurance, obviously the rest of Home Valley, we provide a lot of service out there. It is sat in the hands of the CCG around what they may well use Maple Ward for in the future. I have given some ideas to feed into there. So for instance, Swift, the Kirklees Hospice around daycare. For me, with the gym facilities and everything else that's there, it would be absolutely perfect for a one-stop shop for frail elderly people. So there's a whole raft of workup that they're currently looking at, but it isn't the CCG's intention that they just leave that ward shut. They are actively looking to use it. It just won't be used for the Maple Ward, traditional Maple Ward as it was.
Yeah. I think the Joint Health Committee also had a recommendation on the use of Vaughan Valley Hospital as well in relation to the changes at the acute trust site.
Yeah.
We'll be talking to the CCG about their deadlines for the full intermediate care review, and when it's appropriate for you all to come and talk to the Scrutiny Committee about that. Okay.
CCG are working to a deadline of March for the open one.
Yeah. Right, so your other paper is the local incentive scheme that you've
The ambition of
submitted to us. Yes. So is there anything you want to highlight on here? Now, have you worked it out that on here you've got, one of the acronyms on one of your reports. I can't remember whether it's on this one. ICCT.
Integrated Community Care Team. Sorry, apologies.
We've got that, yeah, go on.
Okay, so in terms of ambition of origins, there was a local incentive scheme put in place from Greater Huddersfield, end of the patch, not North Kirklees, end of the patch. And I was charged with putting into place reducing avoidable admissions of patients known to the CALA. From my point of view, given the work that we need to do for patients anyway, it was just madness not to have that work in North Kirklees as well. So I started a piece of work to look at the reasons why patients are admitted over a certain age group. So I looked at over 65 patients over the age of 65 who were admitted with a 0 to 1 day length of stay, and then looked at the cohort conditions, and they largely related to patients who had experienced a fall, patients with a urinary tract infection, patients with cellulitis, patients with chronic obstructive pulmonary disease, and patients with heart failure. So we began a targeted piece of work to look at patients at risk of falls and patients who had fallen, and patients that had urinary tract infections. And we've got, again, a 2-weekly meeting that tracks the progress, and again, action plans in place for all of the teams. We've had some really good success with patients who have previously been catheterised and had significant amounts of admissions over the course of a week, and through working with them, and those patients get into a position where they don't have a catheter, an indwelling catheter anymore, have actually reduced the numbers of admissions. There is without doubt still work to be done. I don't think I can tackle anything to do with cellulitis, and that, for the detail of it, is because those patients have got to go into hospital to begin with, to have their line put in. Yeah. So I think I'm confident that we're managing the patients and the community for that. I think it's really difficult nationally. It's difficult to target patients with chronic obstructive pulmonary disease and heart failure. They're quite a difficult group of patients to manage, albeit I think if we catch those patients earlier in their disease process, we'll have much more success. But I think from my point of view, patients with falls who just end up, it's just a really not a good patient experience through any stretch of the imagination, that those patients end up on trolleys in the emergency department or indeed on a ward for a day. So I'm really passionate about really making a difference with that.
Okay. On the COPD, is it different times of year, as it appears from your graph, that you get the peaks?
Seasonal.
Yeah, so it's are you looking at if there's any extra support you can put in ahead of those peaks to try and level them out a bit more?
Yeah, and the seasonal is winter and summer.
Yeah.
I mean, on that, while we're on the chronic disease management thing, because we know that a lot of these patients are exacerbating relapse and are in a revolving door position, which when there are no beds in Huddersfield, there'll be less tendency to want to send them because there'll be no way to send them. So what I wondered was, is how you're working with GPs and all this, and in particular, what contingencies have you got for out of hours?
Yeah.
Because it's very easy for the deputising service to come along and not know much about it and say, well, we'll get them in.
Yeah. So in terms of the GPs, we're just starting some work in Greater Huddersfield with 3 GP practices to look at their patients that have got long-term conditions that are at risk of admission. They will have a jointly developed, what we call an emergency healthcare plan, that will be worked through with the patient and will detail for everybody what to do in the event that that patient exacerbates. That will include the work with Yorkshire Ambulance Service, because you rightly say you can put every plan in the world in place. Yorkshire Ambulance Service come in an ambulance and that patient does end up in hospital. So I can't say that I'll be able to solve this immediately, but there are plans in place for what it is that we need to do. The other thing that there is in place in Great Huddersfield is the care home support team, and they work very closely, our care home support team work very closely with the care homes to support those patients, so that the care home are confident to look after the patients don't end up then being admitted.
And have you got nurse prescribers in all this?
Yes, and nurses with what we call clinical skills.
Yeah.
So a level of being able to listen to somebody's chest, somebody's heart, detect if they've got an exacerbation COPD or heart failure.
Actually, just picking up on the Yorkshire Ambulance
Yeah.
side of things, is there a protocol with the Yorkshire Ambulance Service for people who call an ambulance to go to hospital, for the ambulance then to do an assessment before they take the patient to hospital and then divert to a more appropriate location?
There is a protocol in place. The diversion to a more appropriate location is the sticking point. So quite often with patients that are vulnerable, it gets to 8 o'clock at night, the ambulance is called, and then there isn't a service that can swing in quickly to sit with that patient overnight, for instance. That's part of the intermediate care work that we do.
Right. Is the rapid response unit the appropriate unit, is the one?
Potentially. We've got elements, yes. We've got something called START, which is short-term assessment rehabilitation teams. They work 8 o'clock in the morning till 10 o'clock at night. So I'm doing a piece of work to look at what services we can put into, on top of the hospital avoidance teams, into the emergency department, so that the emergency department are confident that we can pick the patient up, take them back home safely, avoid that admission.
Because that's a critical factor.
It is, absolutely.
If the patient is taken into hospital, even though they don't need to go
yes,
there, then
they're on a journey then.
Yeah. And just in terms of the work that is the team got a name that's doing the hospital avoidance work?
It's part of just our general team,
right.
So it's partly district nursing, partly community matrons, there's some work in the specialist nursing teams, and then some in the continence team, and some in the rehab teams.
So do they work to a contract on this particular area, work with set targets?
Yes, so it's part of the care close to home contract, and then that local incentive scheme is the targets.
And is there performance information available in relation to those targets? It would be interesting to see, given the work you're doing, what effect has it had on reducing admission, for example?
Yeah, so the early graphs, I thought I'd include them.
Yeah.
All right.
So they're in there.
It's in an email, I think.
Oh, right.
Yeah, it's embedded in there. It's got a bit of a health warning on it, and I didn't put it in the paper because it's just, it would probably give a whole lot of questions if you just look at it cold. CHFT have sort of introduced something called the electronic patient care record. It has skewed their data around clinical coding. So there are, in that paper you'll notice there's 2 adjustments that have been made, one that we believe is the correct adjustment, one that the Commissioner wants. So we've done the 2 adjustments. I think the point being either way we have reduced, we're confident we've reduced the admissions.
And just on, in terms of 2 appendices, 2 and 3, one's on the high impact change model, the other's on the safe patient flow bundle.
Yes.
How do they relate to each other?
Okay, so the high impact change model is a series of elements that were recommended by the National Health Service Improvement Agency that you need in place to facilitate speedy, safe discharges. The Safer Care Bundle is part of that, so it's part of a ward-based acronym. So it talks about having discharge meetings and ward rounds at 10 o'clock in the morning, having patients discharged before 2 o'clock in the afternoon, and all the things that we know nationally make patients go back into hospital if they're discharged at 8 o'clock at night. So it's that we're working with. So our bit around that model relates to the early discharge planning, the patient flow monitoring. So our community teams pick those patients up in the hospital and work with the hospital discharge management team, so that we can say at the earliest opportunity we can take that patient home and look after them.
Okay, and does the performance management information cover those? There are targets for those elements of the bundle as well?
Yeah, there's a national sequence target in place that says patients need to be discharged to their usual place of residence within 7 days of admission. And that's a shared target.
What is performance like locally?
It's too early to say, and I'm not trying to get out of it, but it's slightly skewed with the EPR data.
And you're looking at the readmission data
Yes.
as well.
Yes.
Yeah.
Thank you.
Okay, thank you. Right, you're into precious paper then.
Yeah.
Which is, I think, this is your last paper, isn't it?
It is.
That we're covering at the moment. So your start team, short-term assessment rehab team.
Yes.
I think you picked up on that one, and this is your ICCT
Yeah.
thing as well.
So this is the local half of the other half of the paper that we've already had through the local authority. So this is the paper that's been jointly submitted through the A&E delivery boards to provide assurance of what the local authority and community services do to support the acute trusts in times of their significant winter pressures that they've had. It has led to us, I have to say, across the 3 business units, really being very solid and robust about our service offer. So, for instance, we've had podiatrists that have looked after patients that traditionally have been looked after by the district nurses, so patients with wounds below the knee, for instance. Medicines optimisation teams, the pharmacists, doing some of the reviews around long-term conditions management. And this is things that we are likely to continue to do in the future, because us, like everywhere else, has got significant pressures in terms of recruitment of registered nurses. So I think if we can reskill the teams to provide probably some pharmacy input and some podiatry input, I think it will be all for the well and the good as we move forward.
Okay.
On page 21, for Huddersfield and North Kirklees,
Yeah.
the first point you've got is that you're only doing urgent visits. Can you explain what urgent is?
Yeah.
Are they that sort of like
So urgent visits would be for the district nurses, patients who need.
It's not clear that you're referring to district nurses.
Okay. Patients that need that need insulin injections every day. Patients that are on syringe drivers that are end of life. Patients who have got very complex wounds. So there is a protocol in place that talks about these are the patient cohorts that we would see. It's all linked to the OPAL, the operating escalation framework. So at the moment, the patients that we may well have not seen at the time of pressures would be those patients with long-term conditions that are requiring an annual review. As it happens, we've picked a large cohort of those patients up through our work with the medicines management team.
Okay, so when you're saying about the urgent visits only, it's just the yearly assessments that are impacted then. There's nobody that should have had a visit that maybe hasn't had one, because the concern is, I think, that if you just gone to, I understand why you go to urgent visits only, but then picking up on the less urgent that you normally go and see, will they escalate to urgent or result in a hospital admission? Do you know what I mean? How do you take that judgment?
Each patient's risk assessed individually on the caseload, and on top of that, when we get to OPAL level, what's called OPAL level 3, there are daily calls that go into place. That is to monitor any teams that are suffering significant pressure through the amount of patients that actually need to be seen, or if there's sickness within the teams. And we move some of the staff accordingly to be able to manage those patients. District nurses are traditionally very good anyway at managing their caseloads. So if patients are seen for a wound, for instance, 3 times a week, it might be in times of pressure that they would have it twice a week with different dressing.
It's just spotting when things are...
Yeah.
That's because one of the other questions I think was the impact on the overall normal workload. How are you assessing that isn't actually being affected?
And I think, as I said, the work that we've done with the podiatrists and their wound care, patients with wound care, and with the pharmacists have had a massive impact in terms of support for the district nurses. So I'm confident we're not left with huge wait lists.
Shall we?
At weekends, do you reduce your staff? regarding, well, district nurses are the main issue where I come from anyhow,
Yeah.
because they really are quite small. I think we go down to one. North Kirklees particularly seems to have a problem at a weekend, and that's when a lot of the people end up in hospital.
We don't go down to one district nurse on a weekend.
Not in for the whole of Kirklees, just in certain areas. There's sometimes quite a big reduction down.
The work in district nursing traditionally, and again North Kirklees is no different, is that you do get less visits on a weekend, and they plan their staffing accordingly to meet the demand. So the average of around probably about 15 to 16 patient visits on a Saturday and Sunday. Again, they'll have a call on a Friday, so that if there is extra pressure within the teams, that they would look to either increase the capacity within the teams or have support from the other two teams. If for instance, if it was Spain, the other two teams battling Tuesday would support them. And that again is kind of part of an ongoing piece of work that the teams are doing.
But you will agree that do find that more patients going over a weekend?
Without looking at the data, I don't necessarily think that is true. So we've just done the latest round of data, funnily enough. So I'm happy to share it, but I have asked specifically for amount of admissions after 8 o'clock at night, amount of admissions on a Saturday and Sunday. Nationally, the data says that the most likely time for admissions tends to be on a Wednesday afternoon. And potentially that is because I think there is traditionally a lot of support, family support around on a Saturday, Sunday. But it'll be interesting to see what that data says this time around.
Yeah, it would. Yes, that would be interesting.
Yeah.
Would that? Yes, it would. Are there any other questions for local? No? Okay, thank you very much for coming this morning and struggling through.
Would it be useful if we came every quarter and gave you a general update rather than a huge amount of papers that we've just given you? Okay.
Alright, thank you very much. Okay, we're going to move on to agenda item 5 now, which is the Suicide Prevention Action Plan. Right, so the Suicide Prevention Action Plan then, this is come to scrutiny. The Select Committee asked all scrutiny panels to look at how the Suicide Prevention Action Plan is being implemented in each area. And you've provided us with the Prevention Action Plan and a summary report which we've read through. Is there anything you want to say just in summary before we ask questions? Or?
Yes, that'd be great, thank you.
Okay.
Just to let you know, my name's Rebecca Elliott. I work in public health and I lead on public mental health and oversee the suicide prevention work locally for Kirklees.
And I'm Emily Harrison, consultant in public health. And I've come to work in disguise today with curly hair, and it's confusing a lot of people that have been to scrutiny before.
I thought you were regular attendee.
Well, I've never been before, but thank you for inviting us to come along. And I'm seeing this as a really good opportunity to actually engage and get some feedback. Just to kind of say right at the start that our local action plan is really, really based on our Kirklees suicide audits that we do. So we try and do them every 3 years, looking retrospectively back, and that involves actually going to the coroners at Bradford and pulling out every single file where there's been a suicide verdict, and looking in detail at circumstances surrounding that suicide. So rather than just looking at websites of national statistics for Kirklees, for example, the audits provide us with a much richer picture and understanding of perhaps reasons why and the particular kind of risk profile, if you like, that we have in Kirklees. So our local action plan is based as much as possible upon those suicide audits. But obviously I am aware that you provided like a list of questions that you tried to answer within the paper. So I'm happy to kind of take any questions that you may have, or I can go through the questions that you asked.
We'll ask questions. We're all waiting.
Hi, yeah.
Hi.
Just on page 28, point 2, you've given a breakdown in the years 2011 to 2013, Kirklees average 8.6, 2013 2015 9.7, 2014 2016 10.0, against the average in Yorkshire, Humber and in England. So if we just look at 2014-16, there's an increase in there, and it's above the national average. Firstly, the increase in terms of quantifying what,
Yes.
what that it'd be nice to say X amount.
Yes.
Is that,
So,
and secondly,
yeah.
was there any significant reason for a rise? I know it's only 0.3%, but if we quantify that to people,
Absolutely.
if I yeah, I mean I don't want to count out. If I've done my maths right, there's a significant amount of people.
Yeah, so first of all, apologies. For this table, I've missed putting the denominator on, which is per 100,000, so hopefully you will have seen that, but apologies. We tend to use 3-year rolling averages just because, although every suicide is a significant tragedy, the numbers are so small that it gives us a better picture to look at a 3-year rolling average, so that we don't get caught up in looking at a particular odd spike or something. But yes, quite rightly, if I've got the actual numbers for you, so for 2014 to 2016 inclusive, that 10 per 100,000 equates to 112 people in Kirklees, and 2013 to 2015, 3-year rolling period before that, was 108. And in terms of answering your question about significant factors, the real main one that we know of nationally is the association with times of recession. The last peak that we had nationally was around 2008, and then it's gradually come down, and therefore, without having done a most recent suicide audit for Kirklees and looking at that real rich data behind the figures, I'll be unable to say, but nationally we know that the evidence tells us that recession has a great impact on suicide rates.
So when are you doing your audit?
So we're at we were due to commence in September, and just due to practicality issues, obviously we can't take the files out of the coroner's office for obvious reasons, so we have to secure an appropriate time for them where we can carry it out, and just in terms of logistics and the office space that they have, we've been put on hold, but we're making headway as we speak on that.
Really hoped we were going to come to you today and we'd be able to go, well, we're doing it next week.
Yes.
But we are doing it hopefully in the immediate future. There's been a logistical issue of gaining access, but
I think it's really important, isn't it, in the prevention, in the area of prevention, to try and get that rich information in order to ensure that the action plan is actually addressing.
Yes. Because at the moment we're going on quite old rich data, and even though it is quite likely that the circumstances behind suicides won't have changed much, that is an assumption I'm making, so I do need to get in there and really see what it's telling me.
Yeah, that's really important, isn't it? Yes.
Okay. In terms of prevention and reducing the access methods of basically people committing suicide, what actual work has really been carried out? I know we can say we're trying to do this pharmaceutically, we try to make sure people don't go by this and that, but what have we identified and what have we done?
So in terms of reducing access to the means of suicide, so from the last audit what we looked at was any sort of self-poisoning or overdose, and we looked at those the medications that were used, and that information when we did the audit back then was taken to the joint CCG meetings to try and raise awareness of what type of pharmaceutical products were being used to take your own life. Other things that we're doing in terms of reducing access to the means of suicide, so for example suicides that take place in public places, for example, so Scamander Bridge falls local authority and is used, is a frequently used location. We try and use the terminology frequently used location rather than hotspot as it's historically been known, just for obvious reasons. So we're trying to, at the moment, do some work around Scamenden Bridge and put a bit of a business case together in terms of how many suicides have taken place there and what each one of those would have cost. Because there is quite a strong evidence base for changing the infrastructure of bridges, for example, that whilst the upfront cost is very big, we're trying to show that argument of cost saving long term.
I just pick up on that bit about Scamenden. I was just going to mention what you said before you said it about the changing the bridges, but realistically, I mean, this is a question, it's not an assumption. Realistically, do you think that if it's harder to do, to use Scamenden Bridge, will that actually stop people committing suicide, or will they find some other method? Is the key point. I'm not sure what the answer is.
The evidence base that we've seen is based on the Golden Gate Bridge, where they've done similar measures there, and it has reduced, I think, halved over a certain period of time. So some people will still find a way to take their own life, but there is evidence to show that if you hire the sides of the building, it will deter people from doing it. And there's also evidence to suggest that doesn't necessarily mean it will offload that suicide to another area. Because don't forget, if we deter somebody at that point, there's then an opportunity for something to happen in between. So again, there is that assumption, which I did as well, that if we kind of do something, they'll just find somewhere else to do it that day. But the evidence suggests otherwise.
What you can never do, you can never ask someone after they committed suicide whether they intend to do or whether they were just crying for help.
And you can't count things that don't happen either.
No,
so one of the challenges of suicide is that you can't.
When 30 odd years ago, when I was a kid, a friend of mine hung himself in his bedroom, and I always wondered whether he actually tried to scare his mum and dad, or whether he actually did want to kill himself. I presume it was the scaring of his mum and dad. But you can't ask him now.
No, there are a few people who've actually survived trying to take their own life off the Golden Gate Bridge, and one of them has actually released a video, and he said that the moment his foot left the bridge, he realised he didn't want to take his own life. And it's a very kind of candid video to show that actually, because some people think at that point it's too late, but actually he said, because I've survived, I can now tell my family that I didn't actually want to do this. And it wasn't until he'd left the bridge that he realised it. So my point just being that actually, even up until that very last point, there's still things that we should be trying to do.
And it's a different method of people taking their own lives, but we know from the evidence of making it more difficult to bulk buy paracetamol, for example. So you now are limited to the amount of paracetamol that you can purchase in any one go. There was some work done to make the packets slightly harder to get into, which have been really quite small changes that have been made, but the evidence is now starting to show that that is reducing the number of people taking their own life. So yeah, all of those times when you're frustrated that you've got a really bad cold and they're only selling you 16 tablets in Tesco's, actually there's a reason behind it, and the evidence is that that's reducing the number of people using that method.
Other supplies are available.
Other supplies are available, indeed.
How many of the 108 people are actually young students or young adults that obviously committed suicide, and how much work do we do in terms of prevention within schools and colleges, especially around the social media stuff as well, because is it that blue whale thing, J-Bar?
Yes.
And how much of an impact has it had locally, kind of thing?
Yeah. Which figure did you refer to at the beginning?
Well, in 2016, 10.0, so is that...
Oh yes, so we had 112.
Yeah.
So I don't know the age breakdown of that, but I look in the last suicide audit to give you the age breakdown, if that would be helpful. So this is 2011 to 2013. So our highest age group for suicide was between 13 and 39. There was 20 people between 20 and 29, and 15 to 19-year-olds, there was 2. So again, we don't know how that will have changed in the recent 3 years, but I'll hope to have that.
Each of those 50, all deaths of children and young people aged under 18 or 25 with learning disabilities, all come to the Child Death Overview panel. So we have a shared CDOC panel between Calderdale and Kirklees. I jointly chair that with a consultant in public health from Calderdale. All child deaths come to that panel for review. One of the challenges of that panel, particularly around suicide, is the delay in between the death taking place and it coming to panel for review. One of the challenges for suicide is that we want to know about these suicides as quickly as it's possible to know about them so that we can put things in place to prevent other ones happening in that local area. So it's one of the challenges for CDOP actually is how we get this information more quickly. But all child deaths are reviewed by a panel and learning gathered from that, and it will feed into Becky's suicide work.
I think it'd be good to have not wanting to have any more numbers on top of that, but you know, I'm on an up-to-date list.
Yes, yeah. So just in response to your question around what are we doing around children and young people. So as part of our action plan, we're trying to build stronger links with Northrop Hall. They run sessions on self-harm, for example, that they deliver to parents and schools. So self-harm is part of the action plan. So whilst it doesn't mean that a young person is going to take their own life if they're self-harmed, what we do know is that it's a significant risk factor. And actually we need to be treating self-harm as an issue in its own right. And whilst it is a coping mechanism and we might need to look at how we support certain coping mechanisms so that nothing worse happens, we do need to look at why that is happening. Because we know from our audit that a significant proportion of people who have self-harmed, who have taken their own life had previous self-harm.
Yes, thanks. Yes, a question on paragraph 1 of the report on page 28. Reference in the third paragraph to the targets for the strategy. So, reduce suicide by 10% across the West Yorkshire population, and by 75% in targeted areas. Just wondered what the targeted areas were.
Yes, so this is a recently launched strategy. This isn't us, anything to do with Kirklees that's launched this. This is the West Yorkshire and Harrogate Care Partnership. So all three mental health acute trusts are overseeing this and they're the ones that are owning it. But even though it's theirs, we obviously want to make sure that we're aligning ourselves to it. And one of the main things that they're trying to do within here is align budgets and pool budgets. So that should help us going forward. So the targets that you just referred to are actually ones that they've come up with. So the 75% reduction in targeted areas is what they're referring to as patients that are actually classed as inpatients or under the treatment of a mental health service. So in a certain sense, it's a targeted population. We know about those people and they're under the care of a professional of some sort. So it might be easier to reach 75% target reduction. The 10% reduction...
Sorry, is that the only 75% target area in patients?
Yes, we're just referring to, yeah. And then the 10% reduction in suicides by 2021 is the target that we're more concerned about, which is a population-based approach. But as you can imagine, much harder because from our audit, again, we know that half of people that took their own life in our last audit were in touch with mental health services, but 50% weren't in touch with anybody. So it's people just walking around Huddersfield Town Centre, and it's about how do we find out who those people are. And that's much harder to put a target on, and that kind of relates back to Emma's point about how we evaluate suicide prevention activity. It is difficult, but the argument is a modellistic one, that we still need to keep raising awareness and just get suicide prevention on everybody's radar. Really, everybody needs to champion it.
And just following on from the targets in your plan,
Yes.
you've got a column which is expected outcomes.
Yes.
A number of those outcomes, I'm wondering how you will measure the outcome, because they're not particularly specific.
Yes, yeah. This is one of the difficulties that we have around measuring the impact that we've had. So one of the planned activities that I want to have for this year, or that I do have for this year, is looking at an outcome-based accountability approach to suicide prevention. So I always think of it a bit like a jigsaw. So for suicide prevention to work effectively, everybody needs to be signed up to that jigsaw. And if there's one part that's weaker, that might be the area that really lets us down. So I want to have an outcomes-based accountability approach to it so that we can really see, in terms of our action plan, which bits of suicide prevention can we actually have an influence on and which bits can we measure. So that's the bit that for me really needs strengthening.
So would we expect some changes in that column?
Yes,
due
yes,
course,
yeah,
It becomes more focused.
We're going to try and have a workshop on that so that we can, it's almost just like our local action group, which bits we actually, could we say that we are accountable to deliver on, essentially. If that makes sense.
Yes, and we know the history of the etiology of all this is about, several million miles deep, so we can go on forever saying why. But I just wondered, and it's interesting to know your forensic work going back to the coroner's office.
Yes.
It's interesting to know how far you follow through the cases that have been taken, and whether you take it back to whether people were already receiving care, because a lot of the turn up and it's not criticism at all, it's an observation. A lot of people turn up first of all as a general practitioner surgery, and the GP might not particularly spot the problem, and that's very understandable. But it might also give them something very poisonous. And I just wondered at that end of it, and I noticed the mental health services have got custody of that, and at their end of it, how many people have really been somewhere along the line had some sort of a label put on them that said, there are alarm bells ringing here, not only missing people.
Absolutely, yeah. Again, one of the
I don't know how far your investigation goes back.
No, well, yeah, so we look at a 3-year period, and as I say, we look at all the coroner's files that have had a suicide verdict. But in fact, the last audit, 2011 to 2013, we actually included 20 cases that didn't have a suicide verdict, so they were either open or misadventure verdicts. Because when we looked at the files, whilst they didn't have a suicide verdict, we felt that there were lessons to be learnt that would be valuable to share. So in terms of following any cases through as such, we haven't done that. We just look at the files and we get the information that we need. In terms of primary care, we know that from our last audit that 56% of people that had taken their own life in that 3-year period had been to see the GP on multiple occasions the month prior to taking their own life. So what I'm trying to do again this year, one of the priorities that as a group we've identified is better engagement with primary care. And whilst this isn't a blaming culture at all, we're not saying that they could have prevented it, but exactly what you said about awareness raising for...
And other helping agencies, abroad and you want to...
Absolutely. So I wasn't involved in the suicide audit here, but as a registrar I did the suicide audit for Bury Oldham and Rochdale on that same time period, actually. And we've had a similar finding that people who took their own lives have been to see the GP multiple times in the run-up, in the recent past. And what I wanted to flag, and what they started to do, is flag where that is a change in someone's behaviour. So if it's particularly for men, particularly for white working class men who don't tend to go to their doctor otherwise, if it's a change in their behaviour and they've suddenly turned up at their GP 3 times in 4 weeks, we want something on the system that goes, are you clocking that this is different for this person, and is this our opportunity?
So to keep that in mind, the people who don't regularly go.
Yeah,
absolutely. And there's something that we can do electronically within that system to flag up and go, this is different.
It's almost the same if you have a long-term condition, when you go to your GP, it comes up on the screen as a reminder to the GP that actually it's almost like we want the same approach with suicide prevention and mental health, really.
What about once you've flagged it up then? Electronically, who's going to take ownership of that?
I've just got a list of people's...
Sorry.
Can I just be shaking? Because I know you have to go.
It's just very quickly about the South West Yorkshire Mental Health Trust Suicide Strategy and how much input Kirklees has into that strategy.
Well, we had input into draft versions of this, for example, but it wasn't necessarily ours. It was theirs that they wanted to launch. But nevertheless, like I said earlier, there is a pot of money that's coming down to suicide prevention work that was outlined in the 5-year forward view for mental health, and it's coming down to the STP footprint. So we need to make sure that as a local authority we are influencing and having those negotiations with the people who are delivering on these strategies to make sure that any bids that we want to put forward to get any of that funding, we need to be heavily involved in that.
Yeah, are you confident that that would happen in terms of the negotiations?
Yes,
and bringing some of the concerns to the table, because South West Yorkshire and Kirklees is, and it's having that voice and input.
And it's what I'm hoping that they will bring is that support for cross-boundary work. So, for example, like Scannerdon Bridge that I referenced earlier, even though the bridge itself is in our local authority, people from all over Yorkshire use that bridge to take their own life. So it's in the interest of all of us to actually come together for, you know, to try and reduce suicide. It shouldn't really be about, well, that's your bridge, that's your bridge, that's in your area. We're all trying to do the same thing. So it's about, I'm hoping that they will provide that kind of pooling and alignment that we need across boundary. And also going back to a point that was raised earlier about data. So at the moment we get our richness of data from our suicide audits, but they're looking back. So by the time we've done the audit, it feels quite old already.
It's not current,
So what we're trying to do as we speak is get Kirklees to have a real-time surveillance approach, so that when a suicide happens, a suicide could happen this weekend, but I have no information at all about where, who, how, methods, nothing at all, and I won't get that data until I do the audit. So what we're trying to do is get a real-time surveillance approach set up, not just for Kirklees but for West Yorkshire, because again there's colleagues like me in all the authorities trying to get the same information, but West Yorkshire Police have that information, and we're just trying to get data sharing agreements so that if I came back here in 3 months and you say to me, are there any trends that we need to be aware of, or is there something happening in that locality? I can't answer that at the moment. I don't, because I'm not on top of the data, because I don't, it's not fed to me. But that's what we're aspiring to. We can be aware of clusters and links between suicides, so that yes, the suicide will have already happened, but actually we need to be able to quickly look at why, to be able to try and prevent further ones, if that makes sense. So I really want more immediate data.
Okay. Okay. How about the language?
Page 31, point 3.1, you've talked about enabling people and communities to do more for themselves and each other. Can you give me some examples of the sort of work that you're looking at doing with the communities?
I'm just trying to find which point it is, because I've got one.
Your page number's different to our page
Oh,
number, sorry.
Oh, sorry. Okay.
Under implications for the parents.
Particularly, you've highlighted suicide as a leading cause of death for men in under 40. So what sort of work are you doing to support those individuals?
As part of the local action plan, I've got a list of the stakeholders and agencies that are involved on the page previous. So many of those are community and voluntary organisations that are actually set up doing things for themselves. There's no statutory agencies involved whatsoever, and what we're seeing and hearing from people who have been suicidal in the past is that actually they're the ones that they really like to engage with, because quite often there's a fear around admitting that you might be suicidal, or that you've attempted in the past and it might have been unsuccessful. So we do have a lot of fantastic third sector voluntary community organisations out there in Kirklees, people with mental health problems, and you don't even have to have a diagnosis of a mental health problem to access some of these. So we're really trying to encourage and get the word out there that these organisations exist, and please access them as soon as you might start to feel any changes. So things like the Basement Recovery Project, we have 2 Andy's Man Clubs in Kirklees, support to recovery organisations like that. We've also done some training for community workers, mental health first aid training for adults and youth. So again, we're trying to spread that message that actually we really need to be giving the same emphasis on mental health as we are with physical first aid. Trying to get mental health champions trained up in the community as well.
Richard?
Just go back to the point you're making about electronic records sort of picking up a spike in attendances. Once that's been highlighted, is there who sort of takes over? Are you assuming that the GPs can say, oh, look, this patient's been 3 times and it'll be 3 years, therefore there is an issue? Are you assuming that's going to happen? Or is somebody else going to pick up the thing and say, Somebody needs to, it's all right having the electronic system,
Yes.
somebody needs to get all of the data and say, like,
Yeah,
do something about it. That's
I would never assume. I think that's the starting point with the GPs. That
tend to agree.
you would never assume. But I think part of what Becky's talking about in that kind of awareness raising and just really getting suicide on everybody's agenda, the GPs are very much part of that as well, so that they become more confident in seeing that spike and responding to it, and also being more aware of all of these brilliant third sector organisations that we have, so that they've got them as part of their resource. So it's not necessarily about the GP responding in a medical model to somebody's mental health issue, because that sends somebody down a particular pathway. What somebody might need is Andy's Man Club or the Basement Recovery Project. They might just need somebody to talk to. So it's to support the GPs to notice it, but then not necessarily pull somebody into a medical model of responding to their mental health issues, to have that social isolation.
I mean medical model. What I meant was somebody's going to do something about it, you know, so direct them to somewhere like the Man Club or whatever. Somebody's actually got to pick up the phone and say, either this person wants you to speak to them, or get hold of the person and say, have you considered it? Somebody's actually got to do something with it.
And I would consider that to be a role for primary care. I don't think that's an unreasonable thing to do.
No, that's not. I think you're probably right. It's just whether they actually choose to do it or not.
So
we'll deliver brilliant training, and then they will.
What we're trying to do this year is do some more awareness raising with GPs, training for GPs, and I'm also trying to get a GP primary care champion to really support this agenda, so that I've got some peer-to-peer influence with GPs. The difficulty that we do have is that we could have a system that flags something, but that man, for example, might not actually go with a mental health. He might not go to talk about mental health. He might go and talk about something else, as almost like a cry for help. So the difficulty is actually knowing what it is that person might be going frequently to the GP to talk about. So in that sense, it's about using our data to say, well, actually, we know from our audits that it's this age group that we're talking about. It's people who've got perhaps a long-term condition already, who've had multiple life stresses, to help them try and almost narrow it down a little bit. It is the difficulty with suicide prevention. It's how we find that person. But that doesn't mean that we shouldn't be doing more trying all of that work.
Yeah, and I suppose, are you looking as well at how, if the GP has actually said for them to connect with the group, or there's a referral being made, how actually has that actually happened? We did a piece of ad hoc work in mental health, and the delays and the connections to the groups.
And it's the support that you wrap around that person in order for them to be able to do it, because somebody in crisis isn't necessarily going to receive that information. Oh, yes, do you know what, I will, I'll go and ring them and I'll be proactive. They're just not in that place.
I think we observed as well more recently the people with a dual diagnosis can be pretty desperate, and they don't fall into a neat mental health slot or a substance abuse slot. They're desperate in the middle.
It's hard enough for us to navigate this.
With schizophrenia and the kind of stronger hand or whatever.
Which is another piece of work Scrutiny are doing it. So,
you referred to the time of change hubs.
Yes.
How much work has been gone into the piloting, and how is that going to be brought into the communities, and obviously the divide between North and this side of Kirklees kind of thing? How is that happening?
So the Time to Change Hub is a pilot in Kirklees at the moment. We put in a bid for some funding to have a coordinator for that work, but unfortunately we were unsuccessful. But I believe there is a new wave of funding available coming this summer, so we will be reapplying for that. And just for those of you that aren't aware, Time to Change is a mental health charity based in London, and their sole purpose is to reduce stigma and discrimination around mental health in the community. So although we were unsuccessful, we tried to still plough ahead with doing something, but on a smaller scale. So we've set up a Champions Fund, so public health funding some Champion Fund activity whereby local third sector organisations can apply for small pots of money to deliver some anti-stigma discrimination activity in the community. So we've just recently had that for Time to Talk Day at the beginning of February. So we had an event at the Basement Recovery Project with people with lived experience sharing their experiences of living with mental health with people who don't have mental health conditions, trying to break down those barriers. Meeting of Minds, don't know whether you've heard of Meeting of Minds, that's a service user group that's set up for people who who've used mental health services. So Meeting of Minds delivered something in Dewsbury Town Hall. That's the first community event that they've delivered, and they were absolutely thriving off it. They've really, really enjoyed it, and whilst attendance wasn't great, it's given them the confidence that they want to do more out there in the community. So they're planning something for World Mental Health Day in October at a new cinema in Dewsbury, I believe. So just trying to support local groups to do more out there in the community, but essentially it's about bringing groups of people with mental health problems together with those that don't, and really trying to just have open, honest conversations about it.
How many champions have you managed to train up to go out into the public, into the third sector groups or other groups?
So we have very few. I'll be honest with you. People, it still takes a lot of courage for people to stand up and talk about their lived experience. So we have a few key champions, but they haven't officially kind of said I will be a champion. In Kirklees Council, for example, as a workplace, we have. I think we now have 17 workplace mental health champions. So I'm doing a lot of work in the workplace as a setting, really. So we've got workplace settings going on, but then we're trying to do more out in the community with the public as well.
Okay. Can I just follow that up? You've got mental health first aid courses that you mentioned.
Yes.
£34,800 from district committee fundings.
Yes.
512 people with mental health first aid. Do you know how many of those were from communities and how many were from organisations? So, stakeholders and partners and from the council. What was the balance?
I don't know the balance in terms of specific numbers, but we have a record, so I can get that to you. I know it is a mix, but I'm not sure how weighted it is on the
Right, okay. I just thought that would give us an idea as to how much the community involvement was.
Yes.
Because I think that would be important from the district committees were looking for at that time. But it would give us a feel for how much involvement there was. Yes, okay. David, you looked.
Yeah, got a couple of questions arising from the action plan. First one is on paragraph 1.4, and in the monitoring column, we've got reduced use of section 136. So this is in relation to mental health nurses being in police stations. And what I wasn't quite sure about was whether that was a good thing or not, reducing the use of section 136. It's a good thing if they go there rather than going to a police station, but is it seen to be better to go to a police station if there are mental health nurses based there? I wasn't quite sure what the dynamic was within that.
Yeah, I'm not sure really. I think when we first look at this, I think the perception is that it's better to have lower numbers of section 136. But I do know that the mental health nurses within the police stations have made a massive difference, particularly for the policemen out on the street who are able to actually, if they come across somebody, they're able to actually just have an immediate conversation with a mental health nurse. Who can access records, for example, that they wouldn't have otherwise seen. So I do know that is making a really big difference.
Yeah, just I think it's probably quite a complex issue.
Absolutely.
It is better if someone goes to a 136 unit rather than to the police station if there's no mental health nurse there. So and the second question was in relation to cost. You've got in your earlier on in the paper, you've got a cost breakdown.
Yes.
But in the action plan, there's reference to funding through community partnerships, which looks like it's quite significant. So your cost breakdowns, they're fairly small amounts, those. But there's also funding coming in from other sources. So it'd be useful to perhaps get a comprehensive figure. Where else funding is coming, that contributes to the aims and objectives of the strategy.
Absolutely. Yeah, so there was quite right when community partnerships existed. They had a whole round of applications really focused on mental health in particular men. So there are quite a lot of the organisations that I've got listed were through that funding, for example.
But that's significant in itself then, because if they don't exist anymore, then will those organisations be able to continue operating without continued funding?
Yes, well some of them have, and I believe some of them haven't, but in the paper that I've put here, that is just particularly from the public health budget in terms of spend. But you're right, in terms of a comprehensive spend.
And also in terms of sustainability.
Yes.
If a lot of the action plan is based on voluntary sector, community sector organisations doing their bit, and they're no longer funded to do that, that's a significant point.
Can we just ask a question on the action plans as well. You've got quite a lot of amber throughout. Presumably that's you're working on those. But one of them was about employers, and you seem to have done work within Kirklees, but they're going out to other employers. Not quite sure how that's worked. So presumably the council has contact with a lot of large employers in Kirklees, which would be a start.
Yes.
So are you making those connections?
This is why I think it might be. I don't know if it's Fred or Amber that one, but yeah, this is one like that we need to strengthen because yes, a lot of work is focused on as the council as an employer. But there are certain workplaces that we know of, for example, that are really proactive and do a lot around mental health and well-being. And it's about how we can take those examples and replicate with other contacts that we have. And so the business hub, for example, that we have, I've been trying to look at what information is on there as an offer to local employers around emotional health and well-being and suicide prevention. And PHE, Public Health England, have launched support packages for employers, like toolkits around suicide prevention. So again, it's about getting those out to the employers, but it's something that we need to work on.
And then the red one, which I was surprised at actually, is improved support for those bereaved of suicide.
Yes.
Is it red? Why is that like that? Because I thought that was a
This is one of my real passions this year around supporting those bereaved of suicide. So we refer to it as postvention, and I see it as prevention in itself to try and stop the cycle from happening. We know that those bereaved of suicide are more likely to experience suicidal thoughts themselves, particularly if they were the one that found the person. So a scoping paper has been written by colleagues at Yorkshire and Humber around different provision for bereavement of those, support for those bereaved of suicide. So there's varying degrees of services that are available. So in Kirklees we had Crews, which were based at Brian Jackson House, but I believe that they've since closed due to lack of funding and volunteers. And we have a SOBS group, which is survivors of those bereaved by suicide. The nearest one is in Bradford, and the one that's in the action plan, which is the nearest one to us, which is in Wakefield, which is a pilot between Crews and the Samaritans. That is open to Kirklees residents, but it's about, I know they're struggling to recruit people in Wakefield to attend, so it's whether Kirklees residents would actually, at a time when they're really, really struggling and be prepared to travel. I would like to see something in this area that when anybody is aware of a suicide, that there's an immediate notification to those significant others that this is available. One of the things that we do have is this booklet, which is Help Is at Hand. This has been produced by the Department of Health, but it's been written by people who have been bereaved of suicide, and the feedback from this has been really positive. People who've said to me, being bereaved of suicide, if this had been available when I went through that, it would have made the world of difference. So because of lack of funding, our minimum offer, if you like, is I want to get this out to as many different places in Kirklees as possible, because currently the Department of Health is providing it for free. So that's what I'm trying to do.
Surveillance work.
It does. I was going to say there's difficulty in doing that.
Yes, to know
if you've got a delay in knowing.
Yes. One important point on that though is to say that this has been written for support if someone may have died by suicide. So there might not be a suicide verdict, but because of the way it's been written, it can be given at that point straight away, immediately, even though we don't know it's a definitive suicide. So that's key, because we don't want to offend families either. But there's so much useful support in there.
Yeah, so presumably work with partners who are close to that work would be helpful.
Yes. So like all local undertakers have been made aware, for example.
Right, okay. So I picked up a few things about the West Yorkshire plan and the local districts plans being to flow more together. Is that perhaps the word to use? Because I thought the West Yorkshire SDP work was supposed to work from place up. So maybe it wasn't in this case, but I thought that was how it was supposed to actually work. So maybe we need to look at that again as to how that work is moving together. Yeah. Also your data sharing, the police and coroner, that would perhaps come back with that. And your GPs,
Yes.
how you're
Yeah.
working with your GPs,
Yeah.
I think that's important as well.
Yes.
Anything else? Anybody's got anything on those points? And your employees. Okay. And the finance. Let's have that finance information. You said about
The relevance of finance.
Oh, yes, yes, yes.
I've been scribbling. I've written it all down. It's fine.
All right. Thank you so much.
All right,
That's
thank you.
fine.
Thank you.
Right. Item 6 is the integration of health and social care, and we've got Phil Longworth and Steve Brennan here to talk about this item. So we've had the paper and read it through. So is there any summaries you want to give before we ask questions? Did you say who you are, please? So people know.
I'm Phil Longworth, I'm Policy Officer in the Council.
And I'm Steve Brennan, so I'm the Senior Responsible Officer for Working Together.
Right. Is there anything you want to highlight?
Not necessarily, I was just going to do a brief run through the structure of the paper, but I'm conscious we're a bit tight on time, so I'm happy just to take questions and comments if that's better.
Well, can you first of all outline what you've got your governance that is going to March 2018? So that's only part of your process for this integration, isn't it? It's just one step.
Yeah.
So how are you moving forward and how are you ensuring robustness of governance in this area? Do you want to first of all address that question?
Okay.
I know that we.
So the thing that we're doing in March is taking the terms of reference for the Integrated Commissioning Board, so the Health and Wellbeing Board for approval. So the Integrated Commissioning Board is going to bring together the work that's currently done under the auspices of ICE, which is the Integrated Commissioning Executive, and the Better Care Fund Partnership Board. And the rationale for doing that is effectively when you look at the terms of reference of those two existing bodies, and there's quite a lot of overlap there between what they're aiming to do. There are some differences, so the Better Care Fund Partnership Board has specific duties around managing the pooled budget, but the idea of what they're trying to achieve are very, very similar. The intention of bringing it together is it simplifies the process and it's much more clear then where those discussions around integrating health and social care, particularly around out-of-hospital services, will take place. The idea there is that because we're conscious that there's some changes in what we're doing, the intention is to run that governance structure in what we've been calling a safe mode initially. So that's a part of getting the new group up and running, working. It's got some areas of focus that are given in the paper in terms of what it's going to concentrate on initially. And it's also got quite a short review point in terms of reviewing whether that new integrated commissioning board is working and whether the terms of reference and membership of that group then need any changes as a result. So again, the idea there is we need to get on and do these things. It's pretty easier getting on and doing them and then working through what that means and whether we've got it quite right and whether we need to change it, rather than agonising too much at this stage about the terms of reference and the membership and so on. So that's how we want to try and bring things together with more focus, make some progress on the areas in the paper that are highlighted as priority areas, but recognising we need to keep this under review as we go forward.
So just to be clear, because the governance structures across CCGs, the council, West Yorkshire and everything, they're getting very complicated out there at this moment in time, because there's a lot that are at the moment of change really at this moment in time. So this is a board between CCGs and the council, and your aim at the end of the day is to have a pool budget, is it, that commissioning board will commission services with at the end of the day? Is that where you're going or is it not?
It could be where we go, but what we've not said at this stage is an express aim to have any further pooled budgets. So one of the things that the commissioning board will do initially is review where further pooling of funds would be beneficial. So it's not a specific aim in itself, but there might be areas where further pooling of funds is helpful. Really the focus of it is bringing the services together in a more integrated way, of which one of the things that you could do to help with that is pooling funds. But there are, again, pooling funds becomes quite contentious quite quickly if you're not careful. So what we want to do initially is we think there are lots of opportunities for bringing things together that are already in existence that potentially don't work that well together and getting them working in a much better way. Having done that, it might then be that it's a sensible next step to pull some funds around those services, or it might not, but we want to do a bit about bringing them together first. And again, what we've said is the Integrated Commissioning Board will identify the scope for any further pooling. It doesn't in itself have the powers to make that decision. It will need to bring that back through the relevant governance structures.
Yeah, it's just that it's unclear as to what your end point is.
Right.
Peter, did you?
Yeah. I mean, only just to say really that have you looked at in practical terms? I realised the point about ownership of money.
Yeah.
Have you looked at what happens elsewhere about Northern Ireland who've been doing it from time immemorial?
Yeah.
Manchester, of course, more recently. Yeah. Have you looked at kind of the evidence?
Yeah, we've. What do you want to do that?
Yeah, we haven't been to Northern Ireland because the legal basis for it is completely different.
Yes,
but we have been to other,
I understand that.
We have been to other parts of the north of England.
We have, yeah.
Greater Manchester.
And other parts of West Yorkshire.
And other parts
to see what they're doing.
Parts of West Yorkshire. I think one of the things we've learned from that is that the structures are only useful if the relationships are in place, and that there's sufficient. I think one of the things that they've discovered in Greater Manchester is that there is actually within the existing legal frameworks that we all operate within enough room for manoeuvre to make the changes that lots of people want to make in terms of bringing health and social care much more closer together and to making sure we can drive out some of the difficulties that we have at every single level of the system in terms of two systems not talking to each other. So the legal framework's there already, but unless you've got the relationships between key people all the way through the system, whether that's about the GP being able to work with the district nurse and work with the social worker, or whether it's the chief exec of the CCG and the council and sort of all the points in between, unless those relationships are strong and people have got a clarity of purpose and committed to integrating things, then you can't make the best use of the legal frameworks that we've already got.
So it's people, not systems.
It is.
Yes,
to some degree.
Sometimes people want to use the system as an excuse.
So one of the things we did, so referenced in the paper, but it was a joint development session a couple of weeks ago. So what we spent most of that day doing was talking around the idea of place-based systems of delivering services and what that might mean in Kirklees. And we spent a fair bit of time talking about things like, well, what are the existing places that people might recognise? So there might be anything from wards to ways in which GPs organise themselves, to ways in which locale are organised district nursing services. We spent a fair bit of time talking about the schools as community hubs. And then in the afternoon, when it was just the two CCGs, but representatives from the local authority were still there, we then went on to talk about what primary care's role in this might be, and primary care home as a way of articulating what that might be. So following that session, and the programme board and the steering group that followed it, what I think we've recognised is there was a groundswell of a lot of enthusiasm for bringing together those initiatives that kind of work out of those hubs or those places into something that's much more integrated, and hothousing that potentially over the next sort of 6 months to see how, if we really put some effort into that, how far can we get in 6 months in terms of integration. And the recognition is that we need to capture that somewhere, so that when people ask us, well, what's the end point on this, that might not be the end point for 3 years, but the end point for, say, 12 months is what that represents. So there's a bit about capturing that so we know what we're going to focus on over the next 6 to 12 months, so we don't lose that focus, but recognising that we haven't yet defined where we think we might be in 3 to 5 years. And again, when we've been to other areas, so for example when we went to Stockport, they spent potentially 2 to 3 years before they were able to articulate what their ultimate aim was. And we don't want to pick something now arbitrarily and then maybe be beholden to something that maybe in 6 months' time might not feel quite right. So so the emphasis for us was very much about getting on with working on the things that we've already got and making sure they're as robust as they can be, as joined up as they can be, recognising that there needs to be some variation between how that might be delivered in different bits of Kirklees, but also recognising that it needs to be, I'm not sure if the word's universal, but a consistent offer across Kirklees, otherwise you end up with people not necessarily getting access to things that other people do. So again, what we've said is we need to capture that in the next couple of months and write that down so that people then have this is where we're going over the next 6 to 12 months. But be a little bit open-minded about what we might want to do after that, because we don't want to pick a 3-letter acronym and say that's what we want, because actually that in itself doesn't help either. It's much more about learning from trying to build on the things we've got and then taking it to the next stage after that.
Okay, because in all of this, at the end of the day, somebody who's needing care shouldn't matter whether it's health or social care.
Absolutely.
They should see no difference in how and who's coming in, in that they just have to say once what they need, and assessments done, and health and social care work together and provide those services seamlessly. Is that where one of your aims, that the person at the end of this is receiving the best possible?
Can I say yes, but?
Go on, what's the book?
The book is part of that legal framework is the NHS is free of course delivery and always will be, and social care isn't.
Yes.
So we can
but it's how how a person, somebody shouldn't have to navigate through that themselves.
No,
there should be a seamless way through at the end of the day, shouldn't there? Because if you're needing help, and you don't. How can you judge whether it's a health or a social care? It should be the systems that do that seamlessly for you.
And also one of the things we want to do in order to try and make that happen as much as we can is get the services aligned in such a way that happens through conversations with people and between people, rather than it being a series of referrals that are often handoffs between different bits of the service, and to try and simplify the way services are, rather than to leave them in a disjointed, complicated way, and have several experts who can navigate you through with it to try and simplify it. And I think the other bit as well for us is the sort of wider things that we can include in there, rather than just traditional health and social care. So in terms of housing links with the police and so on. And that's one of the reasons why we don't want to pick a 3-letter acronym, because they tend to be NHS 3-letter acronyms, and they're not necessarily that helpful in terms of getting the wider buy-in to what we're trying to achieve.
Okay. Can we ask as well about the hubs? Now, we've got hubs, a number of hubs, and we've got a number of localities. So health have their sets of localities. Council have their sets of localities. The council have community plus hubs. There's the schools hubs. And then to add another layer, West Yorkshire have something called neighbourhoods, based on population areas that they're working to. So how is all of this fitting together? If you're looking at where you're best placed to have these services, how are they fitting in with the hubs, the localities? Which localities? Are you looking at the West Yorkshire work or neighbourhoods? How are you actually all putting it together so that it works properly as a whole system approach, and not just it's an extra thing on, well, this hub will have it, and this locality will have it.
That was trying to work through that was the main focus of the development session that Steve mentioned a couple of weeks ago, where there were senior councillors and senior officers from the council and CCG governing. And I think we approached that from the point of view that the first stage of making sense of all that is making sure that everybody knows what all those different things are and why they look like they do. So, for instance, we went through the schools as community hubs, logic and geography with the CCG governing bodies, because particular involvement in. There's one GP who's actively involved in working on developing the hubs, but most people aren't. And similarly, the CCG share they've got two different names. I must confess I can't remember the proper names. And in terms of the way in which the GP practices are being clustered in both north and south, which is different,
So
for a different reason.
Yeah, we have clusters in the north, and in the south it's called Commissioning for Value.
That's what so a key thing has been us all putting our cards on the table and saying we've got different ways of thinking about the population. Let's make sure we know what all those different things are. And just going back to Peter's point before about where's the evidence and how we're learning from other places. We've looked quite a bit of the stuff the King's Fund's produced, which is always a useful thing to do. And the evidence that they've come up with in terms of place-based commissioning is to say, and place-based service delivery is populations around about 30 to 50,000 make sense because they're big enough to have the scale that you need, but small enough for people to actually know who each other are at different levels in the system. Because bigger than that, there's just too many people involved. As Steve said, it is.
That's what the neighbourhoods is at West Yorkshire level. It's those sort of figures, isn't it?
Yeah, and I think all they've done in terms of that, what they're setting out for the STP is again going back to the point you were making earlier. We've been saying that for quite a while. They didn't go with that on their own. There's lots of places, all the areas like Kirklees, etc. saying we need to start doing this at that level and build up from there, because that's where you get enough understanding about what's going on in the local community, who's trying to do what, where's the leadership coming from, is it coming mainly from the school in relation to children, or is it coming from the GPs, or is it coming from police around particular issues, and you can build on that sort of level of geography. I think what we've learned, and this has come particularly through the work with for the CCGs and the schools, is you need to build those as fairly natural, organic things rather than arbitrarily saying, well, this ward boundary works, so let's all use this ward boundary, because experience would suggest that's not going to get us to where we want to get to. The CCGs have, I think, found it much more useful to say, let's work with a group of practices who are committed to working together and can see the real value in it. And they're very fuzzy boundaries, the GP boundaries, because of the registered population. It's not a line on a map. And the same for schools, because of the way in which they deal with the mission areas, the number of children coming from out of the area. So I think what came out of that session was people feeling much more comfortable with the fuzziness of the edges of the boundaries, but knowing that we need to all work towards something around 30 to 50,000. So that's probably about 8 places-ish in Kirklees, but rather than obsessing over is it that side of the road or the other side of the road.
No, but just have something that works. Something that works and that everybody's working. I think that everybody knows and they can recognise. But also as well, bearing in mind that there are a number of people who go outside Kirklees to GP practices that live in Kirklees, because the fact that there's a boundary between one metropolitan council and the other is not. The GP practice is up the road.
Coming to our schools from outside the district, etc.
Absolutely.
Yeah. In a sense, what we were conscious of is we don't want to draw boundaries on a map, and then people can't get across the boundary, because that's not how life works anyway. And we don't want to have a bit of a turf war in terms of whose boundaries are right and whose localities are right. But we do equally need to have things that we know are going to have longevity, so that we can work with a few of those in each area to then get the kind of critical mass and get the conversations going and get things working, so that's how you get the kind of the way in which patients and people then flow through those systems better.
Yeah, but maybe not just have one set of localities for one thing, another set of localities for another thing, another set of localities. Is anybody any questions on this? No? Okay, I think this is a continuing conversation that we'll be having on a regular basis over the next 12 to 18 months. Okay, thank you. Thank you. Okay then, right. Work plan then. So will be hopefully coming in April. Podiatry will come in March. And we will be discussing in April as well, we'll be discussing the work plan going forward. We've had a request to look at accountable care organisations, so we'll be looking at that as well in relation to the work plan as well.
Asked Richard whether look into ambulatory care, and have we looked at the message? Ambulatory care as well as emergency dental again.
Oh yes, now emergency dental services, we need to mention that we're looking for a piece of work at West Yorkshire level on dental services, and we're looking at Bradford and Kirklees are looking to put that piece of work together, because Bradford and Kirklees are the most affected, I think, by the lack of dentists. Yes, so we're looking to do a piece of work on
Is that going to be at the joint?
That would be at the West Yorkshire level. We can sort of bring that back in. Yeah.
And having ambulatory care.
Ambulatory care.
Yeah, I must have. I was off yesterday, so I'm just going to send through.
All right, thank you very much. And the date of next meeting, 3rd